Hello, folks, and thank you for joining us at PA-SOS. In this segment, we're going to talk about heart failure. Heart failure is defined as a decrease in the amount of blood that ends up leaving the heart due to some sort of abnormality of the ventricles. In general, the most common type of heart failure you will see is ischemic heart failure because it is a direct consequence of chronic ischemia of those heart muscles. Therefore, coronary artery disease, which ultimately leads to wall ischemia, is the most common cause of heart failure. Similarly, someone who has had a heart attack will also have decreased functioning of those damaged heart muscles, and they too will have a hard time moving blood in the forward direction, essentially defining heart failure. Although ischemic heart disease, such as coronary artery disease, will be the most common cause of heart failure, it's important to keep in mind that there are a few other things that can also lead to heart failure, such as dilated cardiomyopathy. We talk much more about dilated cardiomyopathy in separate segments, but essentially dilated cardiomyopathy deals with a very thin-walled ventricle that unfortunately does not have the power to move blood in the forward direction as easily, again, defining heart failure. Otherwise, we find that heart failure can also be caused just by general aging, and this makes sense. As you get older, your organs, including your heart, naturally get weaker, and thus it makes sense that with age, those heart muscles will have a harder time moving blood in the forward direction. We can generally classify heart failure in a few ways. One of the ways that we can classify heart failure is determining, are we dealing with a problem during systole or during diastole? In systolic heart failure, you're usually going to deal with some sort of abnormality of the heart's ability to contract. If there's less contractile force of the heart during systole, then it will not be able to move as much blood out of the heart ventricles. Meanwhile, in diastolic heart failure, the biggest problem that we're dealing with is some sort of abnormality in the heart's ability to relax during diastole. Remember that in diastole, we are filling up that ventricle. In diastolic heart failure, we're often dealing with a very small ventricular lumen, such that there's not a lot of space for blood to fill up. Well, if you have very little blood within the ventricle, then there's very little blood that you can actually send out of the ventricle and into your other organs. An example of this might be a hypertrophic heart, where the muscles of that heart are just so thick that they start to diminish the size of the ventricle itself. Thus, there's less space for filling of that ventricle. We can also classify heart failure based upon if we're dealing with a left-sided heart failure or a right-sided heart failure. Now, in general, when we say heart failure, we're usually talking about left-sided heart failure or a combination of left and right-sided heart failure. However, in some instances, we can actually have something called cor pulmonale, which is isolated right heart failure. Cor pulmonale is classically going to be caused by some sort of pulmonary pathology, most commonly COPD, that leads to an isolated right-sided heart failure without any evidence of left-sided heart failure. Keep in mind, however, that in general, most common cause of right-sided heart failure will be left-sided heart failure. And we're going to talk very shortly about the pathophysiology as to why that is. Now, as we said, in heart failure, we have a difficult time pushing blood in the forward direction, or in other words, we have poor cardiac output. Now, that could be because, again, we have some sort of systolic abnormality where the heart's not contracting well, or some sort of diastolic abnormality where that heart isn't really filling up with enough blood such that there's not enough blood to actually push out. In either case, because you have less blood that is leaving the heart, you have less blood that's going to get to your other organs, leading to organ hypoperfusion. Now, these could be things like your skin, leading to cool skin, or your kidneys, leading to kidney disease, or even the heart itself. Remember that your heart needs to push blood out of the ventricles in order for it to start perfusing the coronary arteries and thus itself. Well, if there's less blood that can leave the heart, that means there's also less blood that is feeding the heart itself, further worsening that ischemia because now there's even less blood supply. This is one of the biggest problems with heart failure and the reason as to why it is a progressive disease. In addition to decreased forward flow of blood, we also start to see a lot of backup of pressures as a consequence of heart failure. Think of it like a traffic jam. If you have a car that's stalled and you're on the highway, then you have a bunch of cars that are now stacking up right behind it, unable to move forward. And this continues to progress over and over again until you start to create more and more of a traffic jam. Well, just like the congestion that you can see on a highway that results from an accident, you also get to see congestion within the circulatory system as well. If blood cannot move out, let's say, of this left ventricle, then that means that pressures and congestion is going to increase within the pulmonary arteries and veins, the lungs themselves, the right ventricle, and so forth. And pressures will continuously increase behind the affected region. Well, not only are we getting these increases in pressures, we're also going to start getting leakage of fluid out of these areas. Think about in a highway, eventually all that congestion will cause people to exit out of the highway. Well, we see something very similar within your vessels. For example, within the lungs, the capillaries may undergo so much high pressure that it will start to exude fluid out of those capillaries and into the lung space themselves, causing things like pulmonary edema or pleural effusions. Same thing can happen in the skin, such as in your legs most commonly, where these veins get so dilated and high pressured that fluid starts to leak out of them. Thus, it should make sense how right heart failure may result as a consequence of left-sided heart failure. As the left-sided heart failure continues to increase the pressures behind it, eventually that pressure will build up in the right side as well, leading ultimately to right-sided heart failure, because even now the right heart will have a hard time pushing blood in the forward direction. It should also make sense how something like COPD can end up causing right-sided heart failure. We see in general that when there is chronic hypoxia, there is usually an increase in the amount of pressures within your pulmonary arteries and the lung themselves. Well, if the pressures are starting to increase within the lungs or within the pulmonary arteries, then that pressure will continue to back up, including within that right heart, causing ultimately right-sided heart failure, because the right heart will have a hard time pushing blood against this high pressure that's within the pulmonary arteries in the lung. The clinical manifestations of heart failure make sense when you think about the pathophysiology. Because you're getting so much leakage of fluid out of the capillaries, such as within the lungs, you will most commonly see patients complain of shortness of breath. Many times patients will complain of orthopnea as well, which is worsening of their shortness of breath with laying flat. This is usually because when you lay flat, you're further increasing the amount of blood that is going to return to the heart because there's no more gravity affecting the blood flow. Well, when a heart is barely able to move blood in the forward direction, you don't want to add more burden onto it, which can occur when you lay down. And thus it increases the amount of fluid that ends up leaking out of those capillaries, such as into the lung space. Occasionally, patients will complain of a cough that is going to be productive of a pink, frothy sputum. This is something that the boards really like to use as a description for heart failure, but keep in mind that this is actually rare in clinical practice. And as we said before, left-sided heart failure will eventually lead to right-sided heart failure, and thus we will start to see specific symptoms associated with right-sided heart failure. We'll talk shortly about what those symptoms are, but let's talk about the physical exam in a left-sided heart failure patient. As we said, that we have decreased perfusion of our organs because there's decreased forward flow of blood. Well, classically, patients will have cool extremities because there's decreased perfusion of the skin. When you listen to the patient's lungs, you will usually hear oscillatory crackles. Crackles are usually heard when the alveoli are trying to force themselves open. In the case of pulmonary edema, when you have so much fluid that is surrounding the alveoli, it takes much more force for the alveoli to snap open against all the force that's trying to keep it closed. And you can actually hear it in the form of crackles. You may also hear decreased breath sounds. If you have a big pleural effusion, which is fluid that is building up within the pleural sac, then it makes it difficult for the lungs to expand, and thus you do not hear lung sounds in those areas. Most commonly, you'll hear decreased breath sounds in the bases which is where pleural effusions usually stack up. When you listen to the heart, you may hear extra heart sounds, and it's very important to understand these two heart sounds called S3 and S4. S3 is an early diastolic extra heart sound, and is usually heard because of splashing around of blood within a dilated ventricle. Hence, it would make sense that S3 is most commonly seen in systolic heart failure, where you aren't really contracting the heart, and so blood just pools within that large left ventricle. Meanwhile, S4 is heard in late diastole and is usually heard as a consequence of an atrial kick. The atria normally does not have to really contract that hard in order to try and fill up the left ventricle. However, if you have a very stiff left ventricle, such as in hypertrophic cardiomyopathy or left ventricular hypertrophy, then the atria actually have to push really hard to empty itself into this high-pressured ventricle. And you can actually hear the splashing around of that blood against those stiff ventricles as a late diastolic heart sound called S4. Again, S3 is most commonly going to be heard with systolic heart failure, while S4 is usually going to be heard with diastolic heart failure. Also keep in mind that S3 is going to be heard early in diastole, while S4 is going to be heard in late diastole, things that can make it easier for you to understand a board question about heart failure. Now, as we said, eventually left-sided heart failure will end up causing right-sided heart failure. Well, in right-sided heart failure, we're just seeing a continuous progression of the buildup of pressures behind that right heart. We know that, for example, the jugular vein, which feeds into the superior vena cava, will eventually feed into the right heart. Well, if we're starting to get a backup of pressures and thus a backup of blood, we're going to start seeing distension of that jugular vein, called jugular venous distension. You may also see lower extremity pinning edema, again, because of the fact that we're now starting to get backup within the systemic veins of the legs. Occasionally, you can see something called a hepatojugular reflux. Because we have a hard time moving blood in the forward direction, we're going to see a lot of blood starting to back up within the liver as well. What we find is that if you push on that liver, then it will actually act like a sponge and it'll squeeze all that extra fluid it was holding out of it and cause it to go upwards, but instead towards the jugular vein, causing further distension of that jugular vein. One thing I really want you to keep in mind is that these particular symptoms are related to right-sided heart failure. Thus, if you have a patient with just these symptoms, but no signs of pulmonary edema, that means you're most likely dealing with isolated right-sided heart failure or cor pulmonale, maybe due to some sort of pulmonary disease. However, if a patient has these symptoms as well as pleural effusions or pulmonary edema, then that means the symptoms most likely started as a cause of left-sided heart failure, because it is only with left-sided heart failure that you're actually going to see backup within the lungs as well. The diagnosis of heart failure is typically a clinical diagnosis, but one of the most important tests that you can perform is an echocardiogram. An echocardiogram is able to take a look at something called ejection fraction. Now, it's important to understand ejection fraction as well as how it differs from cardiac output. Remember that cardiac output is the quantity of blood that leaves the heart. Meanwhile, ejection fraction is what percent of the blood that was within that left ventricle actually ends up leaving. Now, for a normal heart, we usually see an ejection fraction about 55 to 65%, meaning that of all the blood that is within that left ventricle during diastole, we only push out about 55 to 65% of it during systole, and this is normal. However, in someone with systolic heart failure, we find that they have a lower ejection fraction, usually less than 50%. This should make sense because not only do you now have even more blood within that left ventricle because it's all dilated, but you're also pushing out even less blood as well because those muscles within the left ventricle are just not as strong as they used to be. Diastolic heart failure, on the other hand, will usually have a normal ejection fraction, This may confuse some students because it may be difficult to understand how you can have a normal ejection fraction but still have low cardiac output. Well, keep in mind that in diastolic heart failure, we really don't have that much blood that can fill up that left ventricle during diastole, such that when that heart does actually contract during systole, it can push out as much blood as it wants because the muscles are still just fine. Thus, the ejection fraction stays preserved. However, because there's a quantity of blood that is much lower, then the total cardiac output is lower as well. There are some other tests that can also help us support the diagnosis of heart failure. For example, if we perform a chest x-ray, we will usually find evidence of cardiomegaly, or an enlarged heart. We may also see evidence of pleural effusions, which again is the fluid that can build up within the pleural sac, and you can see it here highlighted out. In severe cases of heart failure, you may also start to see signs of pulmonary edema, where fluid will actually start to build up within the lung tissue itself, making it much more difficult for patients to breathe. Moving towards the labs, one of the most beneficial lab tests that you can perform is a natriuretic peptide test. Classically, we order either a BNP, or brain natriuretic peptide, or an NT-proBNP. We'll find that there is an elevated BNP in patients with heart failure. BNP is a molecule that's usually released by the ventricles when it tries to increase the amount of fluid that you pee out. The heart realizes that it's overfilled with blood and thus will increase the release of BNP in order to help pee out some of that excess fluid. One of the problems that we find in heart failure is that because the heart is not really able to push blood in the forward direction, there is decreased perfusion of the kidneys. Well, the kidneys think that there's a low blood pressure everywhere because of the fact that it's not getting as much blood, and will thus increase the RAAS, or renin-angiotensin-aldosterone system, in order to help increase the blood pressure. But the RAAS activation has some downsides. One of the downsides is the fact that angiotensin II will go up to this failing heart and say, hey, you're not doing a good enough job. And it will actually start making that heart, which is already failing, work harder to try to perfuse the remainder of the body. One of the things that angiotensin II will do is it will actually induce hypertrophy of those ventricular wall muscles. Now you might say, oh, that's great, because now this heart is going to beef up and finally go back to normal, right? Well, no, because this heart still had poor blood supply. You can have as much muscle as you want, but if you don't have the resources to feed those muscles, which is blood supply, then those muscles will ultimately become ischemic and then die. And at the end of it all, we start to see that the walls of that ventricle will get very thinned out, further worsening the heart failure. By using an ACE inhibitor, we can prevent angiotensin II from exerting that cardiac remodeling effect and therefore prolong the life of people with heart failure. Therefore, ACE inhibitors are one of the few drugs in heart failure that are able to decrease morbidity and mortality, something that is insanely important to know for your boards. ACE inhibitors are one of 3 drugs that all patients with chronic heart failure should be placed on. The second medication in ABD therapy is a beta blocker, such as metoprolol. Beta blockers are very useful in chronic heart failure because they can help decrease the amount of cardiac ischemia. Remember, that was one of the most common causes of heart failure to begin with. Beta blockers will decrease the amount of contractility of the heart, meaning that the heart is working less hard, and so there's not as much stress on those muscles to work and become more ischemic. Meanwhile, beta blockers will also decrease the heart rate. Now, if you decrease the heart rate, that means the heart is going to stay in diastole a little longer. This is insanely important because your coronary arteries are perfused during diastole. Therefore, by decreasing the heart rate, you are increasing your time in diastole and thus increasing the amount of time that your coronary arteries are able to perfuse your heart. Thus, beta blockers will help decrease that cardiac ischemia. Just like ACE inhibitors, Beta blockers are also therefore able to decrease morbidity and mortality in heart failure. The last medication in the ABD therapy is a diuretic. Most commonly, it'll be furosemide, or better known as Lasix. Now, it's important to understand that a diuretic doesn't actually improve morbidity or mortality because it does not decrease the progression of heart failure. All it will do is it'll increase the amount of fluid that you're able to pee out and thus decrease the symptoms of heart failure, like shortness of breath and edema. Now, keep in mind that those ABD medications are for the treatment of chronic heart failure. However, we often find that patients with chronic heart failure will occasionally have acute exacerbations of their symptoms. We call this acute heart failure or decompensated heart failure or congestive heart failure, which we're trying to move away from using that phrasing. The goal in the management of acute or decompensated heart failure is to help decrease the amount of fluid within the patient and help decrease their symptoms. A nifty mnemonic for remembering the drugs that we use for acute heart failure is LMNOP. The L stands for Lasix or furosemide, and as we said before, it'll help in decreasing the amount of edema, like pulmonary edema, by causing the patient to pee more. In the past, we used to recommend the use of morphine in the treatment of decompensated heart failure. However, newer studies are showing that there are no clear benefits and there may in fact be more risk. So that is no longer recommended in the management of acute heart failure. However, I left it here just in case you happen to see it still on your board exam. Another medication that we like to use are nitrates. Nitrates are very useful because they cause venodilation, or dilation of the veins. This is very useful in heart failure because by giving a nitrate, we are going to store more of that excess blood within your veins and keep it away from the heart. It actually is useful to decrease the amount of preload to this heart because it already has too much blood inside of it and it's barely moving any of it forward. Thus, by giving a nitrate and decreasing the amount of blood that goes back to the heart, you're actually taking away some of that excess load from the heart and giving it a little break. The O stands for oxygen, and we really don't need to give oxygen to most of our patients unless they are hypoxic. Otherwise, we find that excess oxygen can actually cause coronary artery vasospasm, which would not be handy in a patient who has ischemic heart disease. Lastly, the P stands for positioning, where we keep the patient positioned upright. And again, this makes sense because if you have a patient sitting up, then we're allowing for gravity to keep most of the blood within the veins, and thus it's harder for the blood to climb against gravity and return to the heart. This concludes our segment on heart failure. Thank you.